to come back up for a discussion. Open to questions from the audience. We have a few of our own as well, but if anyone has any questions for any of the panelists.
Okay. All right. Please identify yourself.
I'm Graham Brown from the University of Melbourne in Australia. Thanks to all the speakers for a really outstanding session. I'd like to talk, perhaps the question is mainly for Dr. Volksman, but others may have interesting inputs. We've always been reluctant for some reason in the malaria community to take on the concept of multiple drugs for chemotherapy. Those of us who treat patients with chronic disease, HIV and TB, we're very used to the idea of multiple drug combinations. And in particular, in those situations, we would never change one at a time because essentially it becomes serial monotherapy. What's happening around the world at the moment, as we've heard at this meeting, is that sometimes essentially people are having serial monotherapy because the partner drug sensitivity is not being tested. Back in the day when we first had these, the idea was to have combination to protect sulfadoxine pyrimethamine was to combine it with mefloquine to have a drug, fancy meth. And the opinion leaders absolutely attacked this. Others also were concerned about a long-acting drug, as we now have, with subtherapeutic doses when a patient received a second infection. So to put the question to you, we have a drug pipeline of 3 to 5 years. Let's say in 3 years, we do have 2 new anti-malarial drugs, efficacious, different modes of action. How would you recommend they be introduced either for treatment of an individual patient or in mass drug administration?
Great, thank you for the question. I think you raise a lot of really good issues around how we select for drug resistance variants and the sequential monotherapies, the residual sort of dosages that are below therapeutic levels, persisting for long periods of time, and those opportunities for selection. I think we have to think about how in an ideal world with 2 new drugs that are very effective, and again, depending upon how they work, I mentioned about like smart combinations, so there's different kinds of thoughts around how we may develop things that actually interplay with each other. So that's something to consider. But I think we have to think about both the utility of those in the clinical area and then the way in which we use things in mass drug administration that are also used clinically that have this sort of, again, risk of resistance that can emerge. So I think this idea, from my perspective, this sort of sequential kind of uses is very problematic because there's a lot of uses of drugs that are not, in an ideal world, we can kind of control that, but I think in the reality, that's very difficult to control. So I think we're going to have to be very strategic about the introduction and, again, the surveillance and monitoring of those drugs. And I haven't given you a complete answer, but those are things to really be thinking about.
Right, and maybe we could just have Hillary comment exactly the same question on the use of insecticides, because I think there are enormous parallels.
Exactly. I mean, I think there are very similar questions that we are facing now with the use of insecticides and thinking about what's the best strategy to employ theoretically, but also what's practical to do, given that you only have, given that we're trying to develop nets that will last for a long while in the field, and therefore things like rotating them in and out are not very practical. So looking at the relative advantages of mixtures versus mosaics, etc. So I think there are a lot of parallel questions that we could learn a lot from the 2 disciplines talking more.
Great. Chris, identify yourself, please.
Yeah, hi. Chris Plow, University of Maryland Institute for Global Health. Chris, this is for you, or Philip, if you have a modeling perspective to bring, that would be great. My question is, you've used RTSS as a kind of case study in this symposium on malaria elimination. And I used to always raise my hand and ask Rip Ballou and others, years ago, do we know what the impact of RTSS is on transmission as such? I think in the early trials, they may have collected gametocyte information, but that was tended not to be reported. Is there any evidence on whether, infectivity or gametocyte counts or anything is diminished or elevated by this vaccine? I kind of, perversely speculated that if it reduces clinical cases and kind of pushes parasitemia down into the sub-patent range, you might even, increase the parasite reservoir. So what do we know about RTSS in the elimination context?
Chris?
So, Chris, very, very important question. I haven't seen the data, but I do not think that RTSS has an impact on gametocytes. Is there any evidence that it has an impact on transmission? None. Okay. But what we do know, and this is it's kind of buried in some of the reports. So the RTSS, the pediatric RTSS in the phase 3 is what I would call a first generation vaccine. Other people would call it an implemental vaccine. Nevertheless, if you look at prevalence, not clinical disease, there is a decrease of prevalence across all the sites up to 50% after 1 year, and after 2 years it goes down to 30% in some of the highest transmission areas. And we're talking in Burkina Faso, in Ghana. And so that, to me, is I'm kind of optimistic about that. It's not a perfect vaccine, but if you can reduce prevalence and not just clinical disease a year or 2 years after, in the absence of a better regimen like a fractional dose, or in the absence of a booster, I think it portends well that it could be used. Now, I'm not naive enough to think that a vaccine should be or can be used in the absence of anything else. But it hasn't been tested with a great drug regimen and really optimized vector control. Because right now, no one's going to use RTSS in elimination because it's not going to get to elimination. There are sweet spots, and I happen to think that it ought to be tested, or other vaccines that have that high efficacy with drugs.
Philip, do you want to comment?
Prevalence by RDT.
Pardon?
Prevalence by RDT. So high.
Prevalence it's prevalence by microscopy, not RDT.
Right.
So it's a little bit more sensitive than RDT, but certainly not prevalence by PCR.
Right. Philip, do you want to comment?
Yeah, just to briefly follow up on that. In terms of most of the studies that we and other groups have looked at, I have not seen any data on kind of the effect on gametocytes and onward transmission once an infection has started. But there does seem to be a reduction in transmission to the individual, include in a variety in each phase of trials, with that approximate 50% reduction in the first year being the big one. And so in terms of most of the studies that we've looked at, that's the transmission reducing effect that has been incorporated into how does that layer on top of drug policy and scale of vector control.
Great. Deirdre, do you have some questions for the panel? Yeah.
Well, actually, I have one question for Hillary about insecticides as a population protection approach, and how even in areas where, say, there isn't, so insecticide-treated bed nets in particular. So in areas, say, where there maybe isn't that much insecticide resistance yet, do we know how effective that is as a population protection approach? I mean, obviously the individual protection bed net with or without insecticide, as long as it doesn't have holes, that's pretty effective for those individuals. But it seems like almost a sort of indirect way of targeting the mosquito.
Yeah, I mean, so some of the earlier clinical trials looking at the efficacy of bed nets, that they came up with estimates of the level of protection, both the individual protection and the community level protection. And the trials that compared to, I think, specifically untreated nets with treated nets to help give you a handle on that. If you've got the insecticide on the bed net, you're going to get the community level protection. If you just got untreated net, it's only personal protection. Right. And the sort of magnitude difference between those two is you get twice as much protection in the community if you've got the insecticide, provided your mosquito population remains susceptible.
Right. Okay, thank you. And then I just have sort of a more general question for anybody on the panel. Just this idea, because we've touched on this idea of the role of evolution. Obviously, it's a three-species system. There's a lot of evolution going on. And we often think of evolution as working against us and against our efforts. And for the mosquito and for the parasite, obviously they have a much higher reproductive rate. They've got that going for them. But any thoughts on combinations of interventions or ways of, or interventions that maybe we don't have yet that we'd like to have that might use evolution to our advantage? So really just...
Yeah, I mean, I think, again, analogous to the smart drug approach that's being discussed, there are some promising signs in some of the insecticide resistance mechanisms that we see that actually might increase susceptibility to other insecticides. So I think it's playing on that on what's evolving naturally and seeing how you can use that to your advantage. So I think that, again, we do see that with some of the insecticides we currently got available, that where we get very high levels of pyrethroid resistance, we seem to get less, they become more susceptible to some of the organophosphate insecticides, for example.
Okay, thank you.
And maybe, do you want to comment on this ivermectin effect, which we've been hearing about at the meeting? Because it's a completely different concept, right?
Yeah. So, I mean, the ivermectin idea here is that mosquitoes feeding on people that have taken ivermectin will have reduced longevity. And so I guess the challenge there is the duration of the effect, as I understand it, that there's not how long it remains active in the bloodstream, and also the pressures that it might exert on resistance to ivermectin that's obviously widely used for NTD control as well. So.
Great. Anyone else want to comment on that?
I could just reiterate the idea of the smart drug combinations, and I think one of, we sort of see we see this in natural sort of settings where there's these trade-offs, as I talked about, with drug pressure, and obviously in drug design there's a lot of consideration of this. And just to highlight some of the work, Rick Fairhurst is looking now, trialing in Southeast Asia, where they see these changes in, say, copy number variation, where piperacin is sort of driving down potentially, or it seems to be found in parasites that have a PFMDR1 copy number that's low, and then there are other drugs that, like mefloquine, that may be more susceptible to that population. So again, using these sort of ideas of trading off and in combination, and I think these are sort of early days, but those are important studies to keep our eye on in terms of how we can use the evolutionary trade-offs in natural populations.
Great. Maybe, the audience is thinking of more questions. Maybe I'll ask one.
Can I add one extra comment?
Oh, sorry.
One of the other real advantages of combinations of interventions is looking across multiple axes of pressure on the disease system. For instance, it's not just what is being proposed is not just rolling out one type of pressure at a time, but combining vector control with increased drug pressure and case management and so on. Any drugs that any parasites that might develop drug resistance in a single individual, if all of a sudden vector control in that area means that individual doesn't transmit as much, that's going to actually, system-wide, be a later catch for anything that got through that bottleneck. So that's another thing as far as defeating resistance. You don't have to win every single thing in every single person, but at a community level, you can still actually keep resistance from emerging and spreading.
Great. Well, that's a great lead-in, actually, to the question that I was thinking about. So maybe for Kumar and then for anyone else that wants to comment. I think one of the challenges now is, and I think Kumar gave us a good, kind of overview of how we can detect these various things using methodologies. But now the question is, how are we going to develop a decision tree, right? If you need to tailor, as Chris and Philip were saying, each and every site or each and every, however you define your local area, if you need to tailor a suite of interventions and surveillance tools, how are you going to make those decisions, and how are we going to think in a systems way? And maybe Kumar, you could start, and then others, because I think that's going to be a challenge. As one looks at those lists of possible things one can do and things that one can measure, how are you going to use this in a practical sense?
Okay, thank you, Diane. I think in that it's an excellent question. The bottom line is when driving the malaria to zero, that's the ultimate goal for all of us here. So you need to have basically in the absence of a perfect vaccine, as Chris alluded, how are you going to achieve that, and what kind of information you need? So clearly when we drive down the parasite load to very low levels to the elimination level, then you need to kind of figure out where the transmission is ongoing on. Because you cannot roll over your interventions all over the country. So the whole idea of whatever the surveillance mechanisms we have, it is really to detect where that human to vector transmission is going on. Once we knock them down, then that's the way we are going to knock down the malaria. So whatever the decision tree that we use, that's where it needs to be focused on, and that's where, like, one of the things I was trying to emphasize in this discussion was about the potential use of serology as one of the tools. It needs to be, furthermore evaluated how to use that.
Great, thank you. Anyone else want to comment on how we're going to make a decision tree? What to apply, when and where? Maybe we need, this is maybe a time when the field actually needs to begin to bring decision scientists into this more scientifically driven discussion, because I do think this is going to become an issue.
Yeah, just a comment as well that I think as we are probably going to be moving into an area where we need more tailor-made solutions for different settings, is a real issue of capacity and local capacity to make those decisions. And most malaria control, or many malaria control programs, don't have a single vector biologist on the committee making those decisions. So, and I'm sure there's other cases of similar lacks of capacity. So I think that's going to be a major issue going forward.
Great. All right. Oh, Philip, do you want to?
No.
Okay.
Robert Perry from PMI in Kenya. Just to build on that, I mean, it'd be interesting to hear this discussion in terms of what actually can happen in a country where, changing treatment paradigms, changing drugs, changing nets, changing insecticides is not a trivial matter and takes a lot of work, in terms of regulatory work, implementation work, monitoring work, and to have different parts of the country have different strategies, given population movement, given treatment seeking, given all that, it's all makes me wonder how, you can do some, it'd just be interesting to hear what you all think about how you can tailor things regionally, in terms of Afro or Emro, nationally and subnationally, given the sort of programmatic challenges of having different things happening in different parts of a country or a region or whatever.
Right.
Thanks.
Great. We'll let Philip take this one.
I think it's really important to kind of understand what is the both spatial, political, organizational, and time areas in which you can have a defined policy. That's just one of the constraints that goes into how you scale things up. One of the real key challenges, I think, that where all of these things would start is that everywhere you're going to need improved case management and kind of case tracking and surveillance. You need that early, you need that in the middle, you need that late, you need that to prevent reintroduction afterwards. And that's kind of a no regret thing. And as that happens and as that gets scaled up, a lot of the subnational picture, a lot of the areas where there might be a lack of knowledge gaps about the local epidemiology will become somewhat clearer over time. Is there all of a sudden a continued clinical incidence during times when you thought the vector population was really low? That's actually something worthwhile to dig into. What's happening with the local vector biology? What are the populations that are driving transmission during that interval? And without that type of information, which needs to get built up anyway, it becomes a lot more difficult to tailor it. I think it's not just a question of what is the type of tool that needs to be done there, because that takes years to kind of turn over and set up the policy. But it's once you have that set of tools and be watching out to make sure they're still effective, where do you focus on ratcheting up coverage even higher at a subnational level? And that can be layered and done on top of a scaled up and improved surveillance and case management system.
Okay. Question.
Hi, this is Flaminia Cateruccia from the Harvard THM School of Public Health. I guess this is a question for Hillary in terms of knowledge gaps and for insecticide resistance. So how much do we know what it is that causes this resistance? Is it actually the use of bed nets or indoor resistant sprays, or is it agricultural use of insecticides? And how would this knowledge influence our decisions in terms of control and management of insecticides?
Yeah, and that's a hotly debated topic, and because of course it has big implications for when we're designing new insecticides and where whether their use is restricted for public health or in agriculture. And I think there's now a good evidence base to suggest that resistance to pyrethroids at least did emerge first in areas where there was high agricultural use of insecticides. So that triggered the first emergence of resistance, but the scale up of vector control has driven it to extremely high levels. And I think it is going to be, I think that's why for something like, or any of the insecticides that we currently have are all used for public health and agriculture. They all came from agriculture originally. So even with the best designed resistance management program in the country for public health, there's very little you could do to manage resistance with our current tools. With the new insecticides that are being developed, they fortunately have a target product profile that's probably going to mean that they are less likely to be deployed in agriculture, and therefore we may have more ability to develop a robust resistance management strategy in the future.
Great. Thank you. Just want to thank all of our speakers for a very thought-provoking discussion about these interventions that do not exist in isolation, obviously. Just this emphasis that one thing I heard was that we really have to tune these combinations to the local environment. You need research going on in those environments to do that, but you also have to balance that with, as somebody mentioned at one of the questions, you have to balance that with what you can do in terms of national programs. So thank you, everyone.
Thank you. Safe travels.